I want to welcome you to this Focus Symposium, and as I do that, I'm going to say how grateful we are to be here, to the WCPT for their ongoing support of ethics, and I'm told by a number of people how important that is in the WCPT agenda, and also I'm reminded that ethics is not something that's secluded. It's something that's a part of our everyday lives. We're going to be talking about that today in the symposium, and so we're very happy to be here. As you know, the format for this is a panel discussion, and we will each be presenting, and then at the end we'll have some questions. First of all, I'm Dolly Swisher. I'm an associate professor and coordinator of professional education at the University of South Florida. Also assistant dean for interprofessional education in the College of Medicine. On this illustrious panel, and I want to say I'm delighted to have such an international collection of ethics experts. We have Gail Jensen. Gail is the Dean of the Graduate School and Associate Vice President for Academic Affairs. She is also a Professor of Physical Therapy and Faculty Associate for the Center for Health Policy and Ethics at Creighton University. I think Gail is well known to all of you. She's also the recent recipient of the Mary McMillan Award of the American Physical Therapy Association, and she's the author of over 60 publications and over 200 national and international presentations. Seated on your left is Mr. Aziz Ahmad Adel, who is a Bachelor of Physical Therapy, and he's a teacher of physical therapy and has been the director of the Physical Therapy Institute in Kabul since 2003. He is also vice president of the Afghan Association of Physical Therapy and has held this position since 2005. At this time, I would like for you to join me in giving Aziz applause as probably the speaker who had the most trouble getting here. His story is remarkable for having tried to get his visa in a number of different countries. He was a week in India, and we're just delighted that he could make it here. Seated next to Aziz is Jeanette Praestegaard. She's been on the physiotherapy faculty for 13 years and is senior lecturer and program manager at the Center for Interconnected Social and Health Care at Metropolitan University College of Copenhagen in Denmark. To her, and next to Jeanette is Clare Delany. Clare is a senior lecturer in ethics, law, and qualitative research methods at the Department of Physiotherapy, the University of Melbourne, and she also is clinical ethics fellow in the Children's Bioethics Center at the Royal Children's Hospital. We also have joining our panel Ian Edwards, who teaches ethics, sociology, clinical reasoning, and musculoskeletal physiotherapy in the School of Health Sciences at the University of South Australia. From 1983 to 1987, Ian lived in Kabul, Afghanistan, and at that time he undertook the commencement of training physiotherapists in Afghanistan. Also a collaborator who's not here for the panel. You see our empty Ruth Purtillo chair, but Ruth Purtillo, who is well known to you for her work in ethics and Professor Emerita at the MGH Institute of Health Professions in Boston, Massachusetts, assisted us and worked with us in planning this session, but was unfortunately unable to make it to the session. So here is the panel, and with that, let me just talk about the panel, Forging Links to Moral Action, Reaching Beyond Boundaries. And these are our objectives for the session. First of all, we're going to talk a little bit about the scope and limitations of physical therapy codes. Second, we want to talk about what implications that might have for us as each of us working from the individual, community, society continuum. And we want to think about strategies that educators, researchers, and practitioners might use to link these concepts. And we will be talking with these main focuses, and I'm going to talk to you a little bit about the limitations of codes of ethics and give you a kind of a global picture, and then Dr. Jensen will be talking about the ethical implications of social determinants. Then Aziz, Adel, and later Ian Edwards will talk about ethics education in Afghanistan. Jeanette Praestegaard will be talking about clinical practice implications, codes of ethics, and ethical concepts. Clare Delany will then be talking about the social individual public health continuum. So, thinking about traditional codes of ethics, it's worthwhile noting that a number of countries have recently revised their codes of ethics. And when we look at those codes of ethics, we find that, one, we know they're important documents, but as someone just before the meeting reminded me, a code of ethics is not just a piece of paper. If you don't live it out, it's not important. So most of us, it's not just the code of ethics, but beyond that, we can recognize that all of our codes have certain limitations. We recognize that as a profession, just to have a code of ethics is the mark of a profession. But when we have a code, it doesn't make us an ethical profession necessarily unless we live it out. So it's a public affirmation of duties. And we will refer to these for guidance when we have questions about ethical situations. A code of ethics can establish ethical expectations. At the same time, it can set an ethical ideal. And I know when we were working with our revised code of ethics in the American Physical Therapy Association, we had a long discussion about to what extent should we put into the code of ethics a high bar? Should it be a really high standard? Or should it be more of these are the minimal expectations? And we could have some debate about that. In spite of the fact that codes of ethics have a somewhat similar formula of rules, broad principles, core values, they all do have some limitations. I like to think, as Linker described it, about codes of ethics really being a window into how we see our work from an ethical perspective at any one time. And codes are indeed a window to our own ethical expectations for ourselves. At the same time, it's not a window only into our ethical expectation. It also allows us to see how we see ourselves in the practice, political, and social context. With that in mind, let's think a little bit about the limitations of codes of ethics pretty much across the world in physical therapy. First of all, I would say that one limitation has to do with the philosophical assumptions that the codes have. And the philosophical ethical basis for most of these codes are really Western philosophy. As physical therapy becomes more and more a global concern, we can ask ourselves whether the philosophical assumptions are adequate to what we're trying to do. And we also have evolved from medical practice, and medical practice has been very influenced by what we'd call the four principles approach. In fact, some ethicists jokingly refer to what they call the Georgetown mantra. I'm hoping I haven't offended anybody, but autonomy, which means the right to self-determination, beneficence, which is trying to accomplish the good, non-maleficence, which is preventing harm, and justice, which has to do with fairness. And those four principles allegedly would be the basis for most ethical decisions. But there's been a great deal of literature since this kind of came onto the scene in the 1970s about the limitations of this kind of philosophical approach. For one thing, they're very individualist in their orientation. They tend to be very deductivist. And they also tend not to include certain contextual and situational factors that most of us would consider important. Now, Beecham and Childress, who were the authors of this particular perspective, would say that these principles simply represent the common morality. But as we look across the stage especially at the World Congress of Physical Therapy, we can ask ourselves, Are those four principles, would they be the same really if we ask physical therapists? Are those the four most important ethical concepts? So as we talked about, the assumptions about the autonomous individual from an ethical perspective become somewhat problematic. Likewise, when we said that the code is a window, we think about the ethical assumptions. Part of that window is into the cultural and societal assumptions that we're making within our codes of ethics. And those also have to do with the idea of the autonomous individual. We also presume that these are universal principles, separated from contextual information, and probably crowd out communal orientation. So it's more about the individual than the communal society. And as we know in the world, there are many communal societies. There are also some things that occur, and this probably is as true of the American Physical Therapy Association, about marketplace arrangements. We may be concerned about reimbursement, but those may not necessarily be universal. So, the last point I think too is about religious and cultural values. There may be attitudes about gender and about authority that are built into our codes. The third major area, besides philosophical, ethical assumptions and culture and society and religious assumptions that may be embedded in our codes, has to do with practice setting. And I think from the context of the world stage, that's probably as difficult to capture as any. But we may assume certain things. For instance, we may assume that the physical therapist has the ability to take action, a certain level of autonomy that may not actually be the case for all physical therapists. Likewise, we have ideas about the relationship and the practice setting between the physical therapist, the patient, and the family. And finally, and I want to give Ruth Purtillo credit, one of the things for this particular, not her slide, but some of her ideas, one of the things that Ruth was very concerned about was the idea that there are underdeveloped or missing concepts in our code. So we have those four principles that are very well represented, as well as some core values. But some of these ideas, for instance, care, interdependence, solidarity, vulnerability, and partnership, probably aren't as well represented as the ideas of justice, the autonomous individual, and professional autonomy. Likewise, we haven't looked at societal types of factors such as health populations, interprofessional relationships, what do we owe colleagues. These things may be less well represented in our current codes. So, in summary, codes of ethics are very important documents. Simply to have a code is a significant achievement, but we recognize, particularly at this juncture as physiotherapy matures throughout the world, that it may be time to look at the limitations that these codes have for us. So, especially with regard to culture and religion and the social context. So we now will hear from other members of the panel. I'll leave this quote with you. A little bit about the limitations. Turner has recognized that culture and religion are not well represented in bioethics, and that we have to have a more sophisticated understanding in order to be healthcare practitioners of our ethical obligations with regard to those. And for those of you that are not familiar, with Tampa, this is where Tampa is located. Yeah.
Right next to the ocean. Okay. As I put together this talk, I came up with the need to uncover. So uncovering the concept of social responsibility. So that's what we're going to do. And I'm really going to talk about two things. I'm going to talk about social responsibility and the concepts that uncover social responsibility. Then I'm going to sort of paint the canvas of three ethical concepts that are going to be further developed by the panel. I started with the WCPT ethical principles, and there are two principles that relate to social responsibility: respect. Respect is fundamental to everything we do. I tell students in the ethics course, if you only remember one thing in this class, remember respect for human dignity. That's a great place to center your moral compass. The second principle here has to do with this broader notion of addressing the health needs of communities. And you can see by the language in the sub-concepts, physical therapists have a duty and an obligation to participate in planning, to provide optimum community health services. The second piece is the need to work towards achieving justice, and you'll hear more about justice as we go along, in the provision of health services for all people. So I think where we put the emphasis is absolutely critical. These are some concepts from some work done in the U.S. on a documentary, but it's a very helpful tool in helping students understand that health is not necessarily related to health care. That health care, and we do a lot of it in the U.S., has a minor influence on the health status of the people in our country and across the world. That health is more than health care, and health is strongly related to the distribution of resources. And the choices that people make are often related to the choices that they have. And stress, chronic stress in living in oppression or poverty is toxic and has an effect on people's health. And social policy is health policy, and we all pay for poor health. So these are important ideas to help students understand. Also, the World Health Organization had a commission on the social determinants of health. And one of the things that I believe applies to physical therapists is this last piece, the need to measure and understand the problem and assess the impact of the action, which has to do with how do we build capacity among our health professionals to really address these social determinants. And I think that's a good piece for our conversation as we go on here. Sometimes we're confused where we see ourselves. Are we here on the left with the profession at the center of our universe, or is society at the center of our universe or our world? And if we get ourselves in the center of this circle, then we begin to think about our own autonomy, our own recognition, our own access to patients. Versus if we center ourselves on society and what society needs, then we think about the autonomy of the patient, the well-being and the health of the people that we serve. That's a very important, although this looks simple, it's a very difficult concept sometimes for students and therapists. This leads us to the social contract, understanding what a social contract is. If we understand we have a societal responsibility, then we are receiving benefits from society, autonomy to self-regulate, to have our own code, to material benefits in terms of reimbursement and salary. That's in exchange for meeting those societal needs. And this was taken from the American Medical Association. Their code in 1847 stipulated that physicians had to attend to the public health. I'm a big visual person, so this is another way of looking at this. Again, if we stay on this side that just focuses on the health profession, and what is it about us, our institution, our organizations, our representation, our practitioners, and don't really translate the expectations and the obligations that we have in meeting that social contract with society. That's not easy. As we know, it's a social, cultural, political process. But that's what we're here for. And sometimes we stay too much on our own side versus what does society need from us? How does that direct what we do in our profession? And then the regulatory influences, which we've had our full share in the U.S., and it looks like you're starting to get more of this as resources are scarce for health care. And social determinants, many social determinants, but again, these social determinants occur upstream. Living conditions, lack of education, no health care coverage, homeless, stress, nutrition, violence. These kind of environmental and social factors do have an effect on health. This is one of my favorite slides. If we look at thinking about the common good, healthcare is one piece in the puzzle of common good in our societies, as well as, do you have housing, do you have education, do you have work, what kind of environment, do you have clean water and air. But then when we look at breaking down health care, then we've got a lot that goes into the health care good. Then we compete, I believe, for healthcare dollars as they go to acute or trauma, administration, home health, long-term care. Where does rehabilitation come into this? Where is the voice at the table? The policy voice, the voice for workforce about rehabilitation and prevention. And that's where we've got lots of capacity, I believe, to build that capacity for our social responsibility. And if we have a commitment to health, then what is our social responsibility? Do we only focus on the delivery service, or how do we begin to address these factors that influence health? Environment, distribution of power, money, resources, drivers of everyday life. This is not an easy question to answer. We do some work with our medical students at our institution, and they really grapple with this concept. Okay, and on to these three concepts for ethical implications: respect, social justice, and moral agency. Respect, I'm going to start here with a quote from Dr. Ruth Purtillo. Respect is as it allows health professionals to more fully understand their role as contributors to the well-being of society and the self-respect required for sustaining their contributions. Everyone's health is important, and that includes mutual respect and for human dignity, as well as mutual respect for the interdependent teamwork. So respect is a very broad ethical concept that I believe has lots of application for us. The second is to push beyond justice and distributive justice. We often talk about scarce resources, the distribution of justice, whether it's allocation of organs, but I think social justice has so much to lend to health professionals in understanding what our role is in our social responsibility. I've also spent 16 years in a Jesuit Catholic institution, so I know a little bit about social justice. It's in the air. But the role of a profession cannot be understood unless you understand the organizational and social context in which you work. And again, delivery of service or that commitment to health. And this includes health of the most vulnerable population, like Dolly said earlier. The vulnerability, professions are really here to really help the most in need. Historically, that's what we were about, if we are a true profession. So we need to be concerned about the vulnerable populations and be a collective advocate for societal health. Again, beyond justice, understanding vulnerability and the discrimination that really underlies that vulnerability. People don't choose to be homeless. People don't choose. Sometimes they go from the choices that they have. And understanding that is the first step, that kind of critical reflective process, and then helping students and therapists move beyond that. And a second point is understanding solidarity, and that was another piece that Dr. Purtillo is quite interested in. Solidarity is learned not through doing volunteer service work or a health screening or serving in a soup kitchen, but it's learned through contact and being for and with others, understanding that community, helping the community develop their own structure to address some of these issues. There's Mark Kaczewski, who heads up an ethics center at Chicago Loyola, talks about the pedagogy of discomfort, that you need to move students to really understand that and experience the discomfort so that you can see how the dominant culture shapes the way we see the world. And again, that digging deeper for social responsibility. And finally, moral agency, which you're going to hear quite a bit about, as a broad concept that we have responsibility, obligation, and authority to do something. And we can be an agent to act with care for others' best interests. We can help others act and support them in that. And we can be part of taking an action that will make a difference in the outcome versus not doing anything. I also tell students that no action is an action. Complicity is not okay. And finally, advertisement. We started with an advertisement. And this is the advertisement for ethics education, which I believe is one of the most important tools that we have. Ethics education helps Students, therapists uncover meaning. It's part of your thinking, your narrative thinking. You'll hear more from Clare about that in your clinical reasoning and judgment and decision-making skills. Ethics is about the ability to handle uncertainty. If all we wanted to do was to prepare professionals to handle certainty, we wouldn't need to go to school. The hallmark of professional education is the ability to handle uncertainty, and we can't lose sight of that. Evidence is fine. Evidence of all sorts is needed, and when there's no right answer, you've got to use that reflective discernment process to really figure it out, and that's the judgment skill of a professional. And then the critical self-reflection. If you really can't have that critical self-reflection, you really don't have a place to start. So I believe that ethics gives us the perfect opportunity to do that across the continuum, the professional continuum. And I'll show you where Nebraska is. This is your geography lesson. Nebraska is in the center of the United States, the absolute center, and Omaha's right on the river where we were having a flood when we left. So lots of corn and wheat in Nebraska. Not much geography. So Aziz is next.
In the name of Almighty Allah, good afternoon, ladies and gentlemen. It's very honor of me to be here today and sharing some of my experience, which I and my colleague Ian Edwards had in Afghanistan, to share it with you. Afghanistan is a mountainous country in the central of Asia with 30 million people living, and the capital is Kabul. Physical therapy started in Afghanistan in 1983 by a non-governmental organization, which the name is International Assistance to Mission, and of course by the demand of the Ministry of Health of Afghanistan. The curriculum originally was a 2-year curriculum, which was developed to a 3-year curriculum in 2008. The total number of physiotherapy in Afghanistan is around 300 people, with variety of education. 17 is a 4-year education, 105 3-year education, 178 is 2-year education, and we have a few 1-year education which call them physical therapy assistant. When you hear from media or some other resource the name of Afghanistan, so normally people are thinking that, oh, there is nothing there. There is nothing. But it's not always true. When you see regarding the ethics, so ethics is not a new issue in Afghanistan, as well as in the other countries. So when you see the history, it has a very deep root in Afghan culture and society. Richness of the Eastern culture and Islam added its value to the ethics in this country. And when you see the ancient literatures about ethics already exist in Afghanistan. So, and the example of this kind of literature is one is Avicenna Balkhi, which was lived in 1980s, 1003-7. So he did many literatures, and one of the biggest one was about ethics in medical, which was translated to some other languages and has been used for many years in some other countries. Though ethics has been practiced informally in the medical environment of Afghanistan, formally it was not in the curriculum. So in the medical curriculum or physiotherapy curriculum, it was not taught, but somehow by the medical peoples it was practiced. Physical therapy has been formally taught in Afghanistan since 1983, which physiotherapists are taking into consideration the ethical point of view, but formally in the curriculum it was not taught in the courses. And also physiotherapy in Afghanistan was introduced by organizations, which was mostly Western teachers with they are tied to their own cultural background. And Afghan physical therapists, when we are started to teach ethics in the physiotherapy in Afghanistan, so Afghan physical therapists and also the students, they stated that they already knew that morality and what's wrong and what's right, and they will do this practice. So when we discussed this in detail with them, and then they realized that, okay, that they still need to be help and guidance by the ethics and translate this to their professional daily work. So the first ethics course in Afghanistan was taught in 2008 for the students, and according to the Code of Ethics of Afghan Physical Therapy Association, and also according to the culture of Afghanistan. So a booklet was developed, and this booklet was taught for the medical students, for physiotherapy students in Afghanistan. So when we teach ethics in physiotherapy, students and physiotherapists, so this teaching caused the PTs and the students that they ask themselves that whether their clinical actions are always right, because when they did their practice, they thought that they are always doing the right things. But this ethics caused them to ask themselves this question. This raised the issue, what is right in one place may not be right in another place. So I will tell you the story of a 9-year-old Japanese boy when he asked a question from me. In 2008, I was presenting the situation of persons with disabilities and rehabilitation in Japan. And in one area, a 9-year-old boy just raised one question and asked me that why in Afghanistan a male physiotherapist do not treat a female patient who suffer from the pain. So this was an ethical question. From his perspective, or from the context that boy was living, that was right. And it was unethical to not treat a human, if it's a male or female, who's suffering from the pain. But when you come to another context, to Afghanistan, and see the cultures and the behavior and the religious and all these other things, so these all things will guide you to do your work. So you cannot do on that context. So this means that when you're doing something from one context, this will be right, but from another context, it might not work. So, as you know, there are factors which influence ethics, like culture, beliefs, and so on. Even in Afghanistan, different geographical area and different ethnic groups view morality and what's right and wrong very differently. So when you see or when you hear the name of Afghanistan, so you might think that all Afghans are thinking the same, all of them are the same, and they are doing the same kind of things. That's not right. So when you go inside, you will see that different people, different geographical areas, they are thinking from a different angle toward ethics. For example, when you go to the west of Afghanistan. So if a person walk on the street or society like me wearing the suits and there is uncovered head or do not have a long beard, so that will be somehow unrespected to the people and people are thinking somehow differently. But when you come to Kabul, so this is a different situation, an opposite, and people do not think so. And also, in the big cities like Kabul and some other big cities of Afghanistan, between the families, a man can shake the hands of a woman, and between some families that will be okay. But when you go out of Kabul to a remote area, to a village, this will be very bad. People will not do that. So, what's right and what's wrong? Who is right and who is wrong? So sometimes in ethics, there is things which is not white and black, and sometimes is. When I'm saying that people are looking from a different angle toward this, so I have only another example of this. For example, what you will see in this picture here. I'm asking you, what you will see here? VIP, you say. And all this, maybe 100 people, they say that this is VIP. But I'm saying this is not VIP. Who is right and who is wrong? So perhaps you will say that you are right because this is VIP, and I'm wrong because it's not VIP. But I will show you that I'm right. There's no VIP here. So I will look from a different angle toward this, and you will look from another angle. So you cannot say that Afghans, maybe they are wrong, we are right, or we are right, they are wrong. So sometimes things are like this. And I will share you some of the challenges which are in the ethical, when you're practicing physiotherapy in Afghanistan. We all believe that from ethical point of view, all of our patients should have equal right and access to our treatment. We should not differentiate between two patients who have the same medical condition and provide good treatment for one patient and less treatment for another patient. We all believe like this. And this is not different between any nations. But what will you do living in a communitarian society like Afghanistan, where you have to respect family, the elders of the society, and more people about in society? So I will tell you another short story of Logar. Logar is a province located to the southern part of Kabul, 50 kilometers out of Kabul. And one of our staff physiotherapists are from there. So he's treating patients daily and working in the clinic. One day, he had a patient and working with that. Another patient 1 hour before was coming and waited on the hallway. And another patient half an hour ago came and waited to be treated by this man. Suddenly, in this time, a patient from Logar, from his village, came with a recommendation of the elder of the society, that the elder of society sent this man directly to this physiotherapist, that go there, and there is one of our villagers, and he will help you. And also, when this man knocked the door, opened the door, shake with the physiotherapist and asked it that the elder of the society sent me to you to be treated. And also he mentioned that the father of this physiotherapist, which was living on that society, also recommended that please help this man. So, in this kind of situation, this physiotherapist is in a challenge because he needs immediate treatment, not waiting. So, in Afghanistan, we have a proverb that you cannot carry 2 watermelons in one hand. So here is almost 2 watermelons. You have to drop one of this. You will drop the ethics, the morality, or you will drop the culture, the society, the respect, and all of these things. Both of them are very difficult. So, sometimes you cannot decide what to do in this kind of situation or circumstance. And I'm just mentioning about some other challenges which might be similar to the other countries, like reconciling the patient's expectation, doctor expectation, versus your own professional knowledge and ethical obligations. For example, sometimes a patient come with a paper which is a specific recommendation of the doctors, or the patient has their own expectation from you. He comes to you and asks you that, please pull me on traction, and you will see that this patient do not need it. How you satisfy the patient? If you say no, he will say, I have been sent by that professor, and he knows a lot. Why you are not doing this? And you know that this might be dangerous for the patient. And also, there is another story about telling the truth to the patient. So I will not go to detail in this, but I'm not saying that you do not tell the truth to the patients. But there is a paper, and there is a very interesting story about behind this, that sometimes you will get the problem in some of the society when you're doing this. So finally, here's me with my elder daughter. So I'm just showing this picture that it's not only Netherlands has the flower, we have flower too. Some reference. Thank you very much.
My name is Jeanette Praestegaard, and I'm a part-time junior researcher at the Metropolitan University College in Copenhagen in Denmark, and a part-time PhD student at Lund University in Sweden. So, just to get the geographics straight. My contribution today is a mix of personal and professional reflections and experiences and research, but also reflections from being member of the Ethical Committee in the Association of Danish Physiotherapists. Our Ethical Committee consists of 5 members, where our chairman is one of the 5 executive board members of the association. The aim of the Ethical Committee is to challenge the ethical standard in both the member organization and its individual members, that the profession's ethically and juridically standards and regulations are performed individually and collectively. The purposes for the Ethical Committee are to value and discuss actual professional ethical issues and challenges, and right now we discuss the ethical dimension on equal accessibility to the health services in Denmark. It's also to give statements and opinions about professional ethical issues and challenges to both the executive board, to the membership and to interest groups. And for instance, we have just given statements about ethical aspects of health insurance and of professional autonomy to the executive board, who will take these in consideration when forming new policies or guidelines. And we challenge and advance physiotherapists' ethical standards, and to discuss the codes of ethics and suggest potential need for revision, which we have just decided to do later this year. So as you see, it's a very unique purposes, and purposes very close to both the organization and to its members. Today, I will share with you one of our major discussions that we have in our committee, and that is the Code of Ethics. I will try to challenge our common understanding of values, and to be more exact, to challenge our understanding of the range of values. I will discuss the value of respect in the one-on-one relationship and in the broader relation. My understanding of professional ethics takes origin in the Danish understanding of physiotherapy clinical practice. In Denmark, as well as in the other Nordic countries, there is an overall understanding of the healthcare sector as being based on humanistic and social democratic traditions, an understanding of human life and dignity being intervened and dependent on each other. And as the Danish philosopher Løgstrup, he said, the individual has never with another person to do without him holding something of his life in his hand. Denmark is a very small country and has a population of about 5 million. But despite its size, it's a financially rich and peaceful country. We are financially independent. We are not exposed to violence, to malicious gossip or surveillance, and we have a low rate of crime. We profess to a national church and are used to a rather open and direct debate about almost every subject. The autonomy of the individual physiotherapist is very wide, and therefore there's an explicit ethical demand for the individual physiotherapist to reflect about how to manage the person who has placed some of his life into her hand within the setting of physiotherapy. But my early research shows that the common Danish physiotherapists do not reflect very much about ethical or moral issues in daily clinical practice. My research reveals situations from clinical practice where my colleagues have been ethically aware and conscious about their practice, but also some of my colleagues have not been giving the needed information about examination, diagnosis and treatment plan. They have been sending text messages or talking privately on the phones while treating patients. Maybe sometimes they have been eating while treating, being abusive and offensive, etc. We probably are too well off in Denmark and probably too busy with ourselves to feel the need for ethical reflection. But there is a risk that we gradually step into the ditch of habits, where our perspective slowly narrows as we keep walking on the same spot. There seems to be a mutual, tacit understanding that of course we are acting ethically sound, but I would like to challenge this tacit understanding. The codes of ethics in almost every association of physiotherapy and also in the WCPT are put forward from a value-based philosophy. We express basic values like respect, responsibility, honesty, competence, accountability, quality, justness, fairness, etc. as values we strive for and fight for. They are values that we commit ourselves to and values that we try to live by. So the overall question therefore is, what does it mean to physiotherapy clinical practice to have value-based codes of ethics? So this I will try to answer. As a physiotherapist, I'm both I, with all my personal insight, my experiences, my attitudes, etc. And I'm also a professional with specific knowledge, skills and power who has taken some of my patients' life in my hand. So having this implicit in mind, the first ethical principle in most associations of physiotherapy and in the WCPT too is the principle of respecting the rights and dignity of all individuals. And at first sight, this principle seems obvious and of no need to discuss. But as probably many of us have experienced, values often appear empty, far away from a busy day of daily practice. Values appear empty when the value's contained contrast isn't included. A value is first understandable when we include its contained contrast. Otherwise, values become tautologies, meaning that they can only be true. That makes values meaningless and ineffective. So when we state that we strive for respecting the rights and dignity of all individuals, we need to discuss locally in the clinical practice, nationally and globally, what it means not to respect. We need to confirm respect, but also to deny it. When the contrast is contained within the ethical principle, it indicates that I can only show respect when I know how to show disrespect, in a certain situation. Or said about another value, I can only act and be responsibility in practice when I know how to be and act irresponsible. And I can only be professional when I know how to be unprofessional. So as I come closer to the deeper understanding of the values, we have to be aware that as a rule, I as a person talk about my personal values, but as a physiotherapist, I talk about our common values. That implies that a value like respect both contain my personal and my professional understandings of the value. And in order to really understand the value, I therefore both need personal insight into my own understanding of the value and also insight into how I as a physiotherapist understand the value. And this issue we as a profession has to address explicitly in both education and in practice. It therefore becomes obvious and needed for us to discuss the values on which we form our codes of ethics. The codes of ethics are not justified just by us assuming that we all understand their content in the same way despite culture, religion and policies. A lot of aspects need to be considered as earlier has been put forward. We need globally to take up the challenge to support national discussions and developments of code of ethics. Otherwise, we risk value imperialism, where countries unreflectedly are pushed into values that they themselves have not identified as essential. In the one-on-one practice, an example of respecting versus disrespecting the patient can be knowing when to and not to respect the patient's ability for understanding and coping with information about his prognosis. Legitimately, persons are autonomous when being above the age of 18, being free and being able to understand the consequences of their determinations. But in my experience, some patients who are about 18, who are free and who are capable to understand, still have problems really to understand all aspects and the full consequences of their determinations, and this gives rise to my professional responsibility to seek further content. I need to know the range of the value, I need to know how the range of the value can be lived out in practice. But knowing the range of respect in a global perspective is also necessary. It is necessary that we as a World Confederation knows when we respect and when we don't respect the rights and dignity of all individuals. In many countries, patients have free access to physiotherapy, and physiotherapists have diagnostic rights, are educated within universities, a clear picture of worldwide increased professional autonomy. But how and where does this manifest itself? Where are we as physiotherapists visible within the global society? This I see as a major ethical issue. Physicians have since 1970 had an organization they call Doctors Without Borders. Doctors Without Borders is an independent international medical humanitarian organization that delivers emergency aid in more than 70 countries to people affected by armed conflicts, epidemics, natural or handmade disasters, or exclusion from health care. Despite wars, physicians have access crisscross borders, religions and cultures. They have a badge. They show their badge and they say, oh, this person needs water, and the person is offered water. Well, put in very short. But their individual and professional autonomy is respected and used in respecting each individual patient that they may meet. Here I wonder, where are we as a legitimate profession? We have the legitimate right, and as we declare in our code of ethics, also an ethical demand on us to respect the rights and dignity of all individuals, but we seem not yet to have matured as a global profession to take professional responsibility. WCPT history has shown that we can take action. Declaration of torture, here illustrated, is one of the first times when we as a global profession saw an opportunity to take our professional ethical responsibility, to put our feet down in respect for human rights and dignity. So, let me summarize. What is needed from us is moral courage. Moral courage for us as individuals and for us as a world confederation. We need to openly face and discuss the values we find shall characterize our profession. And by doing this, we have to address and reflect about our values contained contrasts, which probably will open for situations where we could have done better. So hereby I say thank you very much for your attention.
Good afternoon. Each of my colleagues today have raised different considerations about clinical ethics. That is, what matters when thinking about our patients' best interests. As the final speaker today, I'll highlight how these considerations are linked and also how we, as individual therapists, as educators, and via our professional bodies, can recognise and respond to these complex ethical dimensions. Dolly highlighted how a review of the Code of Ethics in the American physical therapy context provided a means for reflecting and reconsidering ethical values relevant to guide physical therapy practice. Gail discussed how social determinants of health influence the type of ethical issues that arise in practice. Aziz provided some very immediate examples of responding to these determinants of health in Afghanistan, and Jeanette has focused on values that are often hidden in codes of ethics, but which help to frame the required attitudes and considerations for ethical practice. Each of these talks have highlighted something that Ruth Purtillo predicted in 2000. At that time, she very accurately forecast an expansion or a shift in the boundaries of our moral considerations, from an early focus on professional identity to a later emphasis on obligations to patients, and more recently, and as we've discussed today, a period that Purtillo described as self-identity and patient-focused identity nested within social priorities. In my own academic teaching experience, I'm constantly learning about this type of diversity of clinical ethical dimensions from my students. My students are generally experienced clinicians who've come back to undertake a master's. When they're asked to write an essay about an ethical issue in their everyday practice, the range covers each of the spheres of ethics that our speakers have raised and which Ruth Purtillo previously identified. For example, confidentiality and informed consent are not just ethical issues confined to the patient-therapist sphere. They're situated within global and health system contexts. So the question that arises from our speakers today is how can we frame our ethical obligations in such a way that allows us to respond to the diverse realities of our everyday practice? To begin to answer this question, let me introduce Toby, who's sitting here in the waiting room. Toby features in a publication recently submitted to physical therapy by Ian Edwards and some of us. Toby has ongoing thoracic back pain. He has a recent diagnosis of type 2 diabetes. He's overweight, although he doesn't look too bad in that photo. He has an unskilled job working as a process worker at a factory. He's married with 3 children, lives in a rundown part of the city. His wife has recently lost her job and in the global recession, and now they're under financial strain in relation to house and car payments. Toby appears to display a lack of motivation and some disengagement with the therapist's discussion around goals related to improving his health and well-being. So what does acting ethically mean for the therapist? The ethical obligation that we're generally familiar with to act in Toby's best interests, I suggest, only just begin with the provision of competent, clinically based physical therapy treatment. The therapist needs to draw from other resources to enhance Toby's capability to engage in self-management actions, including motivating him to access physical fitness facilities, seek out healthy foods. In other words, the social conditions and priorities that Toby brings must be addressed along with the physical presentation. So there's no real boundary between Toby's signs and symptoms that might be formally recorded in his notes or on a body chart, and the narrative about why and how he came to have this problem. From an ethical perspective, this means there is a continuum of obligations, beginning with charting of his presenting physical symptoms and disabilities, through to encompassing the influence of his family, work, circumstances, and so on. Seeing these links is the easy part of the talk. The real question to be addressed, and the exciting development in the profession, concern how we're responding to these ethical considerations. Where along the continuum should a physical therapist position herself? Which sphere of ethics should she be operating in? And at a more academic level, which theory or way of understanding ethics might assist in framing and underpinning these ethical domains? I suggest 3 ways to respond to this question. I think we need to expand our notions of ethical reasoning and what it means to act as a moral agent as a physical therapist. I think we also need to develop frameworks of practice that guide ethical thinking and action in everyday practice. And then we need to make sure that those theories and those practical models inform our ethics education so that it becomes relevant to everyday practice and to the realities of our practice. So let's look at a bit of theory first. At WCPT in Vancouver in 2000, Ian and I spoke of an ethical reasoning bridge here at Sydney Harbour Bridge. That's my nod to geography. As one way to conceive of how a physical therapist might recognise and move between ethical issues that arise from the particulars of a person's experience on one side of the bridge, and on the other, the ethical norms and principles that guide clinical and ethical decision-making. Now, in just 4 years, the progress in thinking and theorising about ethical dimensions of physical therapy practice has moved to recognise a more complex web where norms guiding practice mesh closely with socio-cultural determinants of health and well-being. We now suggest a deeper form of understanding of the patient's perspective, their history and personal circumstances, helps to bridge the gap between the abstract, what ought to be done, and the practical, what can be done. We've also further defined the scope and nature of the physical therapist's role on the bridge. We suggest they need to turn their gaze on themselves and be mindful of the influence of their own professional values and health belief systems. So how might they do this? Practically, what can they do? And here I suggest 3 steps. I think that physiotherapists need to listen actively, not a new concept, but they need to listen from an ethical perspective to the patient, their history, their context, and their narrative. Physical therapists also need to think reflexively. That's generally used in qualitative research terms, reflexive thinking, and in that context it refers to a qualitative researcher being aware of what they're bringing into the research and how they influence the outcome. And I think it's very relevant in the context of today's talk for physical therapists to adopt this idea of reflexive thinking and to be aware of their own perspective and voice in a clinical situation and how that contributes or prevents Toby's capacity to receive a benefit and to make choices for himself. And the 3rd step is to reason critically. And this means more than considering the influence of the biomedical principles which have been mentioned today, but it also involves analysing other theories and influences such as power, opportunity and environment. Finally, how do these principles, theories and thinking steps in clinical practice fit with standard approaches to ethics education? Is there one approach which is more relevant than another? Which approach to teaching ethics do you use? Is there a more relevant approach to link the moral dimensions that we've discussed today? How can we teach students or develop ourselves in ways that are useful to meet Toby's best interests? I've previously outlined 5 strands or general approaches to ethics education. These approaches to the teaching of ethics have grown out of different responses to the fundamental question of what actually constitutes ethical practice for a profession. Often teaching draws from one or more of these approaches, but I suggest that educators need to be clear about which strand they're drawing from so that their teaching is purposeful and meets the ethical issues that arise in their students' future practice. Strand 1, ethics as decision-making for action, is an approach that says acting ethically means making logical and ethically informed decisions. It's very commonly used in physical therapy ethics education. Using strand 1 to guide how you might act in Toby's best interests means identifying the ethical principle that is relevant to his situation, carefully choosing and justifying which principle is most relevant, in much the same way as clinical reasoning relies on a form of deductive reasoning and rationale. In today's session, you will have noticed that this first strand has been expanded beyond the 4 guiding principles to a deeper understanding or to an interrogation of what autonomy means for Toby in his circumstances and what a benefit might look like for him. That is, more than a successful mobilisation of his thoracic spine vertebra, or what a benefit looks like in Afghanistan. It draws from the same principles but applies them in different contexts. The next strand, ethics as professional identity, is another common approach in physical therapy. Professional identity and behaviour is usually linked to objective, detached, somewhat, and evidence-based behaviours. Acting in Toby's best interests, according to this strand of ethics, means acting professionally, understanding your professional role and boundaries, and being clear about your professional identity and your interactions with Toby. Ethics as a form of moral agency is also a strong focus in physical therapy ethics, and I think it partly arises to assist therapists who are usually part of a health team to recognise that they need to assess and develop a capacity to act ethically separate from the team. Using this strand to act in Toby's best interests involves the therapist having a clear sense of moral purpose and understanding of their ethical capacity as a moral agent to act in Toby's best interests. It involves addressing questions such as, what is the scope of my moral responsibility to Toby? What do I need to do to provide a benefit, including to enhance Toby's capacity to change his health-related behaviours? Now, the next strand, ethics as character and attitude, this is really virtue ethics, which hasn't been a strong educational trend in physical therapy. From Toby's perspective, a virtue ethics approach would ask, what attitudes, character traits, such as honesty, compassion, humility, are necessary for the therapist to ensure that the treatment benefits Toby and to ensure that his capacity to engage autonomously is enhanced? And the final strand, ethics as advocacy. This approach to ethics education is emerging strongly for physical therapy. Questions about the scope and nature of the therapist's role in not only providing treatment for Toby, but also acting in some way as his advocate are new questions in the area of physical therapy ethics. So, in today's workshop, the question of what constitutes ethical practice has been addressed through the combined messages from each speaker. Ethical practice in physical therapy does constitute a continuum between patient care, patient advocacy, and an understanding of the community and global influences on practice. Progressing our knowledge and scholarship in this area will involve both philosophical and empirical inquiry to examine what types of knowledge and teaching approaches might help us to forge links between and beyond these boundaries. I hope our talks today have contributed to this progress. Thank you.
Okay, we move now to the panel discussion. So if you have questions for members of the panel, I'd just like for you to move to one of the numbers where there's a microphone and just remind you to state your name and the country that you're from. So if there are questions, and while we're waiting, I'll pose this question for Dr. Edwards. What philosophical or ethical theories do you think are needed? And, Dr. Delany was talking quite a bit about, and we've talked about the expansion of ethical theories, and I know that you've done a lot of thinking about that, and I'll let you speak to that.
Well, Gail alluded in her talk to perhaps a limited way that we've thought about justice in physical therapy. It's been more focused on healthcare resources and subsidiary aspects to that, like access to physical therapy and so forth. And that's very important. One of the difficulties about that has been that it's meant we've thought less about social justice. And another difficulty has been that such issues, when we're thinking about resource allocation, these are issues that tend to be thought about and dealt with at institutional and policy-making levels. But if we are going to orientate our thinking and start to think of physical therapists as moral agents, in other words, people and professionals who have both the capacity and the skills to bring about change for good, then we've got to start to think about justice, I believe, in the clinic, in the conduct of our everyday practice. How can physiotherapists, physical therapists actually enact justice in the conduct of our practice? And one of the more recent approaches to thinking about justice is called the capability theory, and it's beyond the scope of the presentation today to enlarge on that. But briefly, capability theory of justice focuses on the capacities of patients to understand and comprehend the influences on their opportunities and freedoms. So, and that would include the social determinants that Gail mentioned. So to be able to comprehend with the help of the physical therapist what are the things that are constraining their opportunities and freedoms, and as an extension, how do they make the choices they do, which is where it hits the road for us physical therapists, because we're interested in health change, behavioural change, and so the clinical and the ethical come together in this aspect. And so I think a number of us on the panel have been thinking and writing about this, and we hope that it will find its way into the public domain and in the literature soon, so we can further discuss it.
Question at 2.
Hi, I'm Jenny Audette from the United States. And my question is, or I'm wondering if any of you would be able to comment on how, aside from developing written statements and policies and codes, our professional organizations are or could do a better job at enacting some of the things you've talked about, like working toward working on and towards issues of social justice and all of those other complicating things that we have going on in the world.
Yeah.
One of the things I do routinely is when there is a national or international disaster, I sort of take a tour of websites to see if APTA, the American Physical Therapy Association, has anything out there in terms of our public image. And we often do not. We're a little better at that, but if you look at the Nursing Medical Association, and I think Jeanette made a very good point about the Association of Doctors Without Borders. So, yeah.
And I do want to comment myself a little bit about that. First of all, I hope that we weren't really trying to imply necessarily that our professional associations have had inadequate ethical basis. What I think that we're all talking about is that as we have matured, and it's been very rapid in the last couple of years, there's a need to incorporate more considerations. And so when Gail talks about advocacy, I think that's particularly important. Other things that I think we could do, and thinking of the idea that Dr. Purtillo was talking about was solidarity. I think finding ways that we can act in solidarity with other groups, and that partially that's supporting publicly, but it also has to do with community and grassroots efforts. And I think that from an educational standpoint, personally, that we might do a better job of teaching our students how to partner with community agencies to promote health.
Leslie Dawson from the UK. I'd like to just present the panel with a possible scenario and then ask them for comments, if I may. There could be a situation where a physical therapist from a better resource country goes to either practice or teach in a lower resource country and somehow models the fact that concentration on short-term patients with short-term impairment are more important than those with long-term disability, which could lead to the local physiotherapists then concentrating their efforts on better educated urban dwellers, when the problem in the country may be the people with long-term disability who are poorer, less educated, and from more rural areas. I'd just be interested in your comments on that.
Clare?
One comment to that scenario, and I think what it raises is that need for reflexivity to be part of our way of acting ethically. That is, to be quite aware of our own individual influence with a patient, or in the context that you described, our influence and what we're bringing in to another situation, and what likely effect that might have, what ripple effect it would have. And so it means being aware of who you're treating from a sort of country perspective or from an individual perspective, and what you're bringing, and so as not to be imperial or to impose things that aren't useful or relevant, would be my response.
Yeah, and I hope Ian will comment, since I think Ian and Aziz, I believe you've published on this as well.
Well, I'll say something and then Aziz can respond as well. From my point of view, using Afghanistan as an example, there are two axes, if you like, for confronting the physical therapy profession. One is a vertical axis where we're actually still trying to develop the profession and improve the training and maintain a standard of practice. And that's a vertical process. And that necessitates then having relationships with a whole range of other constructs like evidence-based practice and so forth. But then, just as importantly, there's a horizontal strand about creating access to for physical therapy for people in remote places who have very few resources and need physiotherapy badly. And I think, therefore, to answer your question, Leslie, there's a sort of trying to hold two things, in maybe one watermelon in each hand, perhaps. And you know, there were discussions just in the last few weeks about how to both maintain the development of the profession, but also to teach and train more physiotherapists and have them stay in the rural areas, which is a bit of a universal challenge, I think, all around the world. Did you want to add to that, Aziz?
Yes.
You need to.
Thank you very much, Leslie. in the continuous of Dr. Ian Edwards. So that's really a context in Afghanistan. And in one hand, you need lots of physiotherapy because, as I told you, there is 30 million people and there is only 300 physiotherapists. And out of 34 provinces of Afghanistan, only 17 provinces has at least one center of physiotherapy. So, the Ministry of Health of Afghanistan, which they calculated, there is needed 1,000 physiotherapists just immediately. And we have 300, and the duration of the course is a 3-year program. So all of this will influence things. But as Ian Edwards said, that it's not possible to just train physiotherapists within 2 months or 6 months or 1 year and then drop it and call this physiotherapist. You need to think about the profession autonomy and also the standards of physiotherapy as well. So there is only one training institution of physiotherapy in all country. So or the capacity of that institute is just to take 20 students per year and then graduate 20 students or 19 students. So in this kind of regards, we discussed a lot about this in the Ministry of Health of Afghanistan, and also the organizations who are working there. One of the solutions which they found that they wanted to build the capacity of this only one institution to reach to the provinces. They should make for example, some kind of branches to the north, to the west, to the east, and the center of Afghanistan, and then instead of these 20 students, they can take 80 or 100 students. So this would be one of the solutions that we make for that. But I'm sure there is many other ways that you might think about that. Thank you.
Back at 3.
Good afternoon. My name is Celia Paycheck. I'm from the U.S. I'm in my second year of teaching the ethical component in my university. And so I'm wondering if the panel could offer suggestions on how to engage students in this content. I'm actually delightfully surprised, that they will engage with case scenarios and case studies. But actually, I guess more specifically, how can I show outcomes that they're learning the material without just testing them? Because I think it makes them just memorize theories and not really absorb that material. And so I'm wondering if you've had any success in using creative teaching. And before I end, I do want to thank each of you for providing an excellent presentation, but moreover for showing leadership in this area and in guiding our profession. I really do appreciate it.
I've been teaching for close to a decade in ethics, and it's not students' favorite course. I found that the more I integrate clinical reality, authentic cases, and performance, the better the student learning. Probably the most powerful thing I've been able to do is the use of standardized patients, a simulation. And with that, I look critically at their reflections to find out what their thinking is about their interaction with the patient and the case. And my evidence would show I'm more comfortable with students who are uncertain. It's the students that are certain who go into that standardized patient interview and say they're great communicators, they know the answer to this case, and by golly, this is what the patient's going to do. Those students are really, I'm afraid, those students really need intervention. So that goes back to my comment about uncertainty, but it also links to this particular piece about narrative thinking. There are two kinds of thinking. Bruner would say you've got analytical thinking and narrative thinking, and we do very little around the narrative thinking, the meaning, getting insight into their thinking about why they went to this answer. We test too much for the answer, and I think in ethics you've got to get into that reflexive process, get a window into the student's head. And writing is one way. It takes a long time to assess, but I think it's extremely important.
Well, as you know, there's been quite a bit of the literature that's concentrated on looking at case outcomes, and there are some objective measures that you can use, but by and large, those aren't so helpful, and I believe, in evaluating individual students. I think that cases can be helpful, as Gail was saying. I think you can develop rubrics to look at students' case analyses, but I do think that when you're looking personally, when you're trying to look at moral courage and implementation, that can be more difficult. So standardized patients are very helpful. To be honest, I think we could, if anybody had another 3 hours, the panel would probably be interested in talking more about evaluating outcomes. It's obviously extremely difficult to look at the outcomes, but there are ways, and I think narrative assessment and also online dialogue now. I will just remind people, depending on different countries, but students are very into online and texting and those sorts of things. So I've found I've had to migrate away from in-class discussion and keep those shorter, but online students will often have interesting things to say to each other. Okay, 2.
Meryl Gersh from the United States. I'm mindful of a poster discussion session that I participated in on Tuesday, where a colleague, Dr. Patricia McGinnis, spoke about a qualitative study that she did looking at physical therapists' self-assessments on how they were doing with regard to core values. And interestingly enough, the participants talked about that they felt very good about the one-on-one core values, the compassion, the caring, the integrity, but 16 out of 18 participants indicated that they did not feel they were doing well in the social responsibility component in that core value. And when she began to explore why, number one, of course, was time, but number two was that they felt they were ill-prepared to act in social responsibility arenas, and that much of our orientation and education is focused on client singular-centered care. And perhaps at this point, we need to begin to a shift to clients plural-centered care. And I was wondering if the panel would care to comment on that and perhaps give us a way of integrating that concept into our students' education in ethics.
Well, I think that's an excellent question. And I do want to say that during the APTA revision of the Code of Ethics, there was a lot of discussion as to whether we really ought to include social responsibility and addressing public health. So I would say that one of the reasons the students aren't so sure about it is that we're just ourselves reaching some consensus about what our social and public responsibilities are. So that makes it a little bit more difficult, and I think one thing that we all need to do probably is more role modeling. I don't want to say too much, but others have ideas. But I would say that part of the theme of the panel actually is that understanding our social responsibility is an evolving thing for us in physical therapy at this point, and it varies by different countries. So I think that you're right, we need a lot more attention to this. So I'll be interested in what others have to say.
I think there are two strands to this. One will be, as we've been talking today, that we gradually widen and broaden our ethical frameworks and the way we think about ethics. But I think in parallel to that, our clinical forms of practice will go sort of hand in hand with that. I think that acting in the areas of social justice, practitioners will be more equipped as we develop our health promotion skills, as we develop primary health care, which is the term we use in Australia and I think UK and Europe. That kind of coming back from tertiary involvement to more upstream, if you like, to look at what physiotherapists and physical therapists can offer in the way of prevention. So I actually think the answer to your question will lie in the development of both the clinical and the ethical streams.
I think just to add briefly to that, in a small scale way as an educator, is to ensure that you have questions, trigger questions to scenarios which appear to be about the individual person in front of you, and have some questions that ask about the behind the scenes, like where does this person come from, or what's their broader context. So at least you're starting to bring that into mainstream questioning about ethical responsibilities.
But I want to thank you. I want to thank all the members of the panel. I think that the panel raised some excellent questions about physical therapy ethics and what are some directions that we might want to go in embracing more social, cultural, and in broadening our philosophical focus, looking more carefully at cultural practice, examining our values, and looking at respect. I heard a number of themes about respect. So I really want to express my appreciation to the panel that did an excellent job, and thanks to each of you for your attention and your excellent questions, and thank you. That's right. That's right. And again, I would like to thank the WCPT, and I agree with Gail totally. When physical therapy, I can remember years ago, it would be 2 or 3 people at the snack bar. So I'm appreciative of the ethics. I also want to acknowledge that the Dutch Committee on Ethics, I believe, is here. And thank all of you for coming. So thank you for your attendance, and I hope you've enjoyed the World Congress of Physical Therapy.